this talk, which I'm really looking forward to myself. It's really nice to welcome you to our club. I think a lot of you haven't been to any of our meetings before, so welcome to the Rotary eClub of Southern Scotland. We're a very informal club, so please feel free to join us anytime. So I'll let Dennis just introduce our speaker for tonight.
Thanks, President Lynn. Yeah, it's wonderful to see so many people giving up half an hour on a Saturday night. And I'm told that we're competing with Strictly Come Dancing very soon, so we'll make sure it's ended before that starts. But it's important that we come together on this day, World Polio Day, to recognise what Rotary has done over so many years in the name of its End Polio campaign. And it's a real pleasure for me to personally introduce Steve Mannion, who's a good friend of mine, a consultant orthopaedic surgeon who goes by the name of Mr. Steve Mannion, FRCS Glasgow. That's his Sunday name. And we really couldn't ask for a better speaker on World Polio Day, because he is an orthopaedic surgeon of great distinction, because he served for so many years in developing countries. He's worked in countries which are really short of resources, but where there's a massive need. They present very late, and so by the time they arrive, it becomes a very serious operation that he's got to perform. And you know, he's got a distinction of being probably the first, he'll correct me, but certainly the first or one of the first job share surgeons in the UK NHS, where he used to alternate between 2 weeks in his surgical practice in Blackpool and 2 weeks in Africa, usually in Malawi, where he was serving people that were most disadvantaged. He and I go back probably 20 years, Steve, you'll probably correct me, but it's about 20 years. We've had quite a few beers together in different countries in sub-Saharan Africa, and hopefully we'll have many more once this pandemic is away. But it's really to Malawi where both Steve and I are drawn, and where he served as a medical missionary for so many years. And he established a real reputation for some innovative surgery, and also for the training he was doing for local doctors. But I think that's probably enough for me, because I know he'll be embarrassed about me saying all these things about him. He embarrasses easily. Besides, I'm really looking forward to hearing him give his talk. The format will be, Steve will talk for about 20 minutes or so, 25 minutes, and then he'll take questions. And if everyone is sitting comfortably, then I'll pass you over to Steve. Steve, would you like to take it up? I think the slides are up on the screen. I can certainly see them. Yep. And are you in control, Steve? Are you able to move your slides?
So, yeah.
Yeah, you're able to do that. Brilliant. So, Steve, over to you, my friend.
Okay, good evening, everybody, and Dennis, thanks for that invitation. Thanks for the honour of talking to you all tonight about poliomyelitis on this World Polio Day, the 24th of October 2020. I like to think of you as fellow Rotarians. I was a Rotarian. You'll hear later in this talk that Rotary did support some of my work in Africa, and when I came back to the UK from Africa, I undertook to join my local club, Blackpool South Rotary here in Blackpool, and I was even made a Paul Harris Fellow, and I'm very glad to have my opportunity to wear my Paul Harris Fellow medal. I'm sad to say that the club I was in actually has folded now. It was a lunchtime club. I think it became more difficult over the 10 years I was a member for working people to attend lunchtime meetings. The membership became more elderly, and then unfortunately it was forced to close. I'm looking around for another club that will just suit my rather busy schedule, as Dennis knows. I thought I might kick off by just going through a little bit more of my kind of CV and my biography. I qualified in 1989 from Cambridge University. I did my house jobs in Blackpool. And then throughout the 90s, I alternated my surgical training, my basic surgical training, and then my higher surgical training in orthopedics with working for humanitarian medical agencies around the world. On the top left screen here, you see the Carter Hospital of the ICRC in Kabul during its early civil wars in the early 90s. On the top right, you see the King Faisal Hospital in Kigali in Rwanda, where I was one of only 2 surgeons in Rwanda during the 1994 genocide. Somewhat accidentally, I became an expert in the weaponry you see in the bottom left screen, an anti-personnel landmine, of which you see a very severe variant from Rwanda in 1994 in the bottom right-hand side of the screen. I kept on working for MSF, Médecins Sans Frontières, in war zones around the world, alternating with my higher surgical training in orthopaedics at Guy's and St Thomas's in London. At the end of my training, I was headhunted by the United States Department of Defense to run a multi-million-dollar research project into the biomechanics of landmine injury and injury mitigation strategies in terms of protective footwear. On the right-hand side, you see a cadaver in a bomb-proof chamber in Texas on which we did that testing. At the very end of my training, I went for what I thought was going to be 3 months in the small central Southern African country of Malawi. And I recognized there, number one, that there was a huge need in orthopedics in that country. At the time, I only had 2 orthopedic colleagues in the entire country of some 12 million people, Nyengo Makandawiri and Chris Larvey, both of whom Dennis know well. I also saw the challenge there and how rewarding the job was. And I ended up staying for 4 years. And there I became almost accidentally again an expert in the condition you see in the middle of the screen, congenital talipes equinovarus, also known as club feet. In 2003, I was approaching 40. I had no possessions in life that I couldn't fit into a large rucksack and a banger of a car in my mother's garage back home. So I ended up coming back to my native Blackpool, but as Dennis alluded to, a rather unusual employment arrangement, a job share with a consultant orthopedic colleague. I did 2 to 4 weeks in the NHS, and then I was 2 to 4 weeks away. Initially, I thought those 2 to 4 weeks off would be back in Malawi, but then people got wind of the work I'd been doing in Malawi, and they wanted me to my advice in their country. So I really did a consultancy in orthopedic and trauma surgery, advising other low middle-income countries in capacity building and training in orthopedic services. I now have a situation where I'm still very part-time in the NHS. I have a consultant practice in Blackpool and Preston, where I'm the major trauma network lead for the Northwest region. I run the Department of Conflict and Catastrophe Medicine at St George's University of London. And ordinarily, I would be overseas 1 or 2 weeks every month. But unfortunately, as myself and Dennis were discussing earlier on, that's not been possible. I did get to Malawi in January and Bangladesh in February, but since that time, due to COVID travel restrictions, I haven't been able to go. And I do fear for some of my projects overseas by virtue of that restriction. So on to polio. Well, this is World Polio Day, and polio has been known in history since prehistoric times. If you look at carvings and paintings on the walls of the pyramids, you can see otherwise healthy people with withered legs, and it's assumed that that is evidence of poliomyelitis in prehistorical days. The first clinical description dates from a British clinician called Underwood in 1789, and there were significant epidemics and pandemics of polio in the United States and Europe in the first half of the 20th century. So what is polio? Well, it's caused by the poliovirus, and it's an enterovirus. It means it's a virus which ordinarily infects the gut. It's quite a simple pathogen. It's a genome of RNA, ribonucleic acid, in 3 subtypes, surrounded by a capsid or capsular protein. It enters the body by the gastrointestinal tract, typically through contaminated water. There's an incubation in the gut of 3 to 35 days. As I say, the transmission is by the faeco-oral route or by the oral route, and it's a highly contagious pathogen. But in 99% of people, the infection remains in the gastrointestinal tract and causes nothing more than a transient GI illness. But in 1% of people, it spreads via neuronal or nerve pathways. It then destroys motor neurons in the spinal cord, the brainstem, and in the motor cortex of the brain. And this causes paralytic polio, the spinal polio, which really just causes flaccid paralysis of the limbs, and then bulbar or bulbospinal poliomyelitis, which affects the brain stem and the motor cortex. And particularly the brain stem's important because that's the area of the brain that's responsible for breathing. And therefore, if the motor neurons of the brainstem are involved, then breathing is affected. How do you diagnose polio or spinal polio? Well, the buzzwords are acute flaccid paralysis. This is a paralysis that comes on quickly. The paralysis is flaccid, the limb is floppy. It can affect one or more limbs, and there are decreased or absent reflexes. Most importantly, there is no sensory loss. The limb is normally sensate. There is no, unlike, for example, a transecting spinal trauma or an infection which might cause the spinal cord no longer to work, sensation in the affected limb with polio is intact. The laboratory diagnosis is done via a stool sample or swab, much as we're doing COVID. There are 3 different types of wild type. These are the endemic polio. And also, as I'll come to later, there's a possibility of developing poliomyelitis paralysis from the vaccine. This is one of the complications that arises. Once the paralysis has started, there is no cure. The patient is merely given supportive treatment with analgesics, physical therapy, which is important in preventing muscle loss and contractures, and ventilatory support if breathing is compromised. What about the prognosis? Well, a child who gets spinal paralysis, spinal polio, will suffer permanent paralysis, 1 in 1,000 children. So although they can get paralysis temporarily, they'll often recover. In adults, the rate is higher. In spinal polio, 50% will fully recover. 25% will have mild disability and 25% severe disability. Those patients who have ventilatory compromise, they need ventilatory support. And the classic method of delivering that in the polio pandemic and epidemic days was via the so-called iron lung. And you see on the screen there some examples of iron lung. This was really a pressure device which enabled the lungs to expand and contract. And there was an enormous amounts of concern about patients going into these iron lungs for what might have been, if there was no recovery, lifetime ventilatory support. In those who develop spinal polio, 5 to 10% of cases are fatal. And there's also what's now recognized as post-polio syndrome. Much later in life, people who recovered from spinal polio in their younger days do have an effect of the polio. This is, to sort of paraphrase this, is if you have spinal polio, then a number of your motor nerves are permanently damaged and die. But your muscle can do relatively well on a fraction of its normal innervation until later in life, where, for a better analogy, the nerve becomes old and tired, and therefore suddenly the muscle can no longer work properly, subserved by a fraction of the innervation it used to have. Thankfully, we now have immunization. This began as passive immunization back in the late 1940s. This is what you might have heard about with the COVID pandemic. If you take the immunoglobulins, the antibodies from someone who has survived and overcome polio, you purify them and you inject them into someone who is suffering the polio illness, then you can affect a recovery. That was only very temporary because it was superseded by, in 1992, the Salk vaccine, which was using inactivated virus, and then in 1958 by the Sabin, which is attenuated live virus. Taking poliovirus, live virus, attenuating by having it cycle through non-human cells at subphysiologic temperatures resulted in an attenuated virus which infected the gut, which caused an immune response, but which didn't cause the nervous sequelae. The oral administration of the Sabin vaccine led it to being very inexpensive and easily administered on a population-wide basis. The only concern with it is that when it's introduced to a population, there is spread around that population of the attenuated virus, and it can then mutate back to a pathogen which can affect the nerves and once again cause paralysis. And that's a concern I'll come to later. So by virtue of your global programs of the Sabin vaccine, and the Americas were declared free of polio in 1994. And Europe, this surprised me looking at it, only as recently as 2002 was Europe declared polio free. A very substantial landmark this year on the 25th of August was that Africa has now been declared as being polio free. There are still sporadic cases in the Middle East and Southeast Asia. Most of these are related to polio derived from the vaccine. It's a very rare thing, but it does happen, and that's a concern. And it's one reason when polio is eventually eradicated, we're looking forward to no longer needing to use the vaccine that will cause these very rare but still devastating vaccine-related paralysis cases. While polio is now endemic only in 2 countries, Afghanistan and Pakistan. And these are the numbers in Pakistan. In 2016, there were 20 cases. In 2018, 12. But we saw a resurgence in 2019 to 146. And part of the reason for this is the security situation in these countries that complicate and frustrate the delivery of the vaccine to the entire population. And another big setback was in the early 2010s, 2011, 2012 to 14, whereby some of the vaccine, people giving the vaccine were targeted by the Taliban. And part of that may be associated with the fact that the location and eventually assassination of Osama bin Laden had been facilitated by intelligence gathering via a fake vaccine program. But it's important, polio will only be when it is eventually eradicated, it will only be the second human disease which has ever been eradicated, the other being smallpox. Rotary has played an extremely important part in ending polio, in reducing the burden of polio paralysis. And it's been involved in the End Polio Now program for over 35 years. The first program being in the Philippines in 1979. Rotary was a founding partner in the Global Polio Eradication Initiative, and Rotary members have donated over $2.1 billion equivalent into the program. This has managed to immunize 3 billion children in 122 countries worldwide. And the cost to protect one child is as little as $3 per child. Again, the Sabin vaccine easily and inexpensively delivered by the oral route. I might now look just at some of the more medical aspects of polio disability. A child who's had polio, who's developed the spinal paralysis, what are the manifestations from a medical perspective and from an orthopedic perspective? And the commonest one is that of an equinus foot, a foot that is unable to be raised up. And this can either be flaccid, because both the muscles at the back and the front of the calf are weak, or it can be fixed in equinus because there's an imbalance of the paralysis. Another frequent manifestation is the quadriceps. The muscles of the thigh are weakened, and therefore the patient can't stand up or walk, and they end up supporting by pushing back on their knees, and this causes the knees to hyperextend. There can also be contractures at the hip, which prevents them extending their hips. You see this in the child that's walking on all fours in the bottom picture. If there's an inability to control the trunk, then the patient cannot sit effectively without support. And there's instability of affected limbs. A common manifestation is of a short atrophic, or what might be formerly known as a withered limb. And this will almost certainly be a polio origin. And another common feature of all these patients is pain. As I discussed before, the sensory supply to the limbs is still intact. There is no numbness. These are not insensate limbs. An unstable, flail, deformed limb is often painful, and the patient has difficulty walking by virtue of that. An important part in the medical treatment of polio disability is orthoses or splints. These provide support for a flaccid, paralyzed limb. They can correct and prevent progressive deformity. They relieve pain. In terms of the foot drop, the foot that cannot dorsiflex, then the ankle foot orthosis, which you see in the top picture, is what's recommended. For those patients who have the more profound weakness in their lower limbs and their quadriceps is affected, then it's the KAFO, the knee ankle foot orthosis, you see being worn by the child mobilizing with crutches, and some other examples on the right hand side of the screen. But one of the challenges, for example, in Africa, is adequate provision of these orthoses, because this does require a specialised workshop and physiotherapists. So not only is Africa often short of orthopaedic surgeons like myself, but it lacks the physiotherapists to do the physical therapy and also the orthopaedic technicians to produce these aids. For those who are very profoundly affected or have weakness of the trunk muscles, then they will never walk, and therefore they need wheelchair provision and also aids to support their trunk when they're in the sitting position. There is a role for surgery, but I always feel that surgery is a minor role in the treatment of polio patients. The more important bits are the physical therapy and the orthoses. What form does orthopaedic surgery take? Well, sometimes it's just soft tissue releases. If you've got a paralysis and imbalance, then if you release some of the muscles and tendons on one side of a joint, then you balance the limb, you enable the foot, for example, to go into a neutral position, and that can then be supported there in an orthosis, in a brace or a splint. Sometimes that imbalance can be treated by transferring a tendon from one place to another. So, for example, a tendon that is strong, that is normally plantar flexing the foot, can be transferred round to the front of the foot to enable it to be dorsiflexed. Sometimes we work by taking wedges of bone, so-called osteotomies, to correct deformity. And in flail joints, where there is no control, they can be treated by arthrodeses, fusion of the joint in a functional position, enabling an orthosis or a brace to be worn to enable that child or that adult to walk. And very important, I cannot, with surgery, restore strength. What I am doing is preventing deformity and correcting deformity, allowing a brace to be worn such that the patient can then mobilize more quickly. Here are some examples of that equinus foot from paralysis. So the foot's been kept in an equinus position, and the child on the left and the adult on the right are unable to raise their foot up. And the treatment there depends on, if you have the strength in a tendon, you can do this operation, the tibialis posterior tendon transfer. Taking a tendon that might be active going down the back of the calf and transferring it to the front of the calf, enabling the patient to actively dorsiflex the foot. This works well in children because their brains are plastic. Their brain is able to relearn that this muscle no longer flexes the foot down, but instead brings it up. In adult, your brain is far more fixed and has less capacity to adapt to this particular operation. Here's another example of the kind of operation that might be done. This boy has a polio-like syndrome. I do see these cases in the course of my work around the world. This is Papua New Guinea, where you're seeing this, the highlands of Papua New Guinea. I can't definitely say this is polio, because to diagnose polio, I need that stool sample in the acute illness, where there's a viral load that can be detected in the laboratory. What I see clinically is acute flaccid paralysis that has resulted in a deformity such as this, and I'm then trying to correct it so that this boy won't have progressive hyperextension of his knees and ultimately become wheelchair bound. In his case, I use what's called the Chinese bone block operation. I'm taking bony wedges from his thigh bone and his shin bone, and taking his patella and wedging that in the front of the top of his shin bone to stop his knees extending in the way you see in the picture. He can then be fitted with the CAFO, the knee ankle foot orthosis, allowing him to walk effectively and prevent progressive deformity, such as you see in the picture. I've been lucky. I worked in Malawi full-time from 1999 to 2003. By that point, a polio vaccination have been taking place for more than 2 decades. I was rarely seeing the sequelae of polio paralysis, and particularly I rarely saw it in children. And therefore I concede to not having to do a large number of salvage operations on children because of polio. But what I did see a lot of is this condition, clubfoot. And I'd just like to tell you about clubfoot now, because that is I see as the modern day equivalent of the scourge of polio in the less developed world. Clubfoot is also known as congenital talipes equinovarus. It's the commonest significant congenital deformity worldwide. It's commoner to have a 6th finger or a 6th toe, but those are not really significant. They cause minimal handicap. But untreated, clubfoot causes a major disability. It occurs at an incidence of 1 per 9 babies per 1,000 live births. It's commoner in male children with a ratio of 3 to 1. It's 40% of cases, it affects both feet. There are genetic influences, so it does run in families, but this is not the entire story, because even amongst identical twins who both share exactly the same chromosomes, there is only 1/3 concordance. Only 1/3 of identical twins who have clubfoot will both have it. In the other 2/3, only one or other will have the condition. And therefore it cannot be entirely genetic in nature. There must be some form of environmental influence. We estimate that there are nearly 200,000 babies born with clubfoot per year worldwide. Top left hand of the screen, you see a child born with clubfoot in my own hospital here in the National Health Service in Blackpool. On the bottom left, you see a child in Africa. On the right, the two views shows children in Malawi in the top pictures playing football, and in Bangladesh in the bottom one. And in the middle picture, you see what happens if the clubfoot are untreated. Severe, profound deformity. That child is unable to run or wear normal shoes or walk or play football. But all the children you see on the right-hand side of the screen were born with clubfoot and have been successfully treated. Here's my poster patient, if you like, for clubfoot. Meet Martin. When I met him, he was 18 years of age. He's a Malawian. He walked on his knees, not because of polio, not because of cerebral palsy, but because of untreated clubfoot. And the shame of this is that clubfoot is completely and utterly treatable. And the method which we use now is called the Ponseti method. And the top picture shows Ignacio Ponseti, a Spanish surgeon who escaped from Spain, having been on the losing side in the Spanish Civil War, and went to France, went to Mexico, and ultimately settled in Iowa in the United States. He was dissatisfied with the results of surgical correction. The dogma back in the 1950s, right through to the 1990s, was of high dependence on surgical correction of clubfoot and babies. But Ponseti was dissatisfied. He found that although he could correct the deformity, they were prone to recurrence and relapse, and the foot was stiff and painful in later life. He studied the normal anatomy of the clubfoot and devised a method by which the foot could be manipulated to restore normality over the course of a matter of a few weeks. Every week, the child would be manipulated and casted. This only began to be popularized in the late 1990s. Ponseti was never a great English speaker. He only poorly related her technique to his orthopedic colleagues. And it was only really when a group of researchers looked back at the cases that Ponseti had treated in the 1950s and recognized how much better these now adults were compared to the cohort that had been treated by surgical method, did anyone start to take notice of his technique. And it's now been recognized as the gold standard of treatment worldwide. And I was very fortunate in 2004, Ponseti, who's now passed away, sadly, I was able to work with him as a Churchill Fellow in his clinic in Iowa. This is the Ponseti method. The baby often in the UK recognised as having clubfoot in utero on scanning, commences casting as soon as possible after birth, and the foot is manipulated and casted on a weekly basis. Typically, after 4 or 5 weeks of casting, the majority of the deformity has been corrected, and all that remains is a release of the Achilles tendon, which is done percutaneously by a minimal incision, often ideally under local anaesthetic, to complete the correction. A final cast is applied for 3 weeks, and then the child goes into an abduction brace to prevent recurrence, worn full time for 3 months, and then at night time up to 4 or 5 years of age. Our clinics in Africa were at the vanguard of popularising the clubfoot Ponseti method of treatment worldwide. Because we saw so many, the birth rate in Malawi, where I was working, every Malawi woman at the time had an average of 8 children. So we saw, as an orthopaedic surgeon, so many more children with club feet. We heard about the technique. And again, as I was doing a lot of surgical correction, I thought this is the answer. If I got a non-surgical method of treating clubfoot, that is the answer in Africa, because we are so short of surgeons. And Rotary played a really key part in the early phase of this, because my project was sponsored by the Rotary International and by the Rotary clubs of Limbe, Burnaby and San Diego. We had an initial course in the Ponseti method for my clinical workers in Malawi in the year 2000. We did a pilot project in 3 locations for 2 years, and then recognizing that the patients who were able to complete the treatment protocol did so well, we then went to a national project with a training of trainers in 2002, regional courses in November the same year, and then at the end of 2002, we basically had a clubfoot project, clubfoot clinic using the Ponseti method in each of Malawi's district hospitals. This was combined with an awareness program, making sure that all the midwives, all the traditional birth attendants and the parents knew that when a child was born with clubfoot, it wasn't witchcraft. It was something that was a disease that could be treated, and the deformity and disability could be completely and entirely corrected. We did support visits to each of the district hospital and refresher training. And an important part of it was data collection and research in order to validate and prove that this technique was successful. On the basis of the success of the Malawi projects in Zambia, in Malawi and in Uganda, then this became really added impetus for the Ponseti method to be adopted worldwide. And as I said now, it is now the gold standard of treatment. It hasn't stopped there though. So we've been involved in spreading the Ponseti method to countries around the world. But we recognise that in many ways it was dependent on the likes of myself, using the same teaching materials that I'd evolved over the years. And in the last 5 years, we've looked to standardise the syllabus and produce a standard teaching resource. So it doesn't all depend on Steve Mannion anymore. It can be the task of teaching and devolving the Ponseti method can be effectively delegated to other people. And so was born the Africa Clubfoot Training Project, an initiative to standardise the syllabus and the teaching material, develop national and regional faculties, so we didn't rely on the likes of myself travelling from Europe. And this was done by training the trainers, teaching our African colleagues how to teach the technique. We take it for granted. It's not necessarily the case. Our African surgeon or clinical officer might be an excellent practitioner, but might not have the skills necessary to teach that to his colleagues in his native country or to countries around his region. And we had a basic provider course and an advanced course, which now is being delivered across Africa. And you see here in this picture, all the countries in which the Africa Clubfoot Project has been active. And now we aim to have one of those stars in every country in Africa. Moving on from that, we've now taken a public health approach to clubfoot. Let's work out how big of the problem is internationally and what resources we might need to mobilise in order to completely abolish clubfoot deformity and disability across the world. taking the same kind of approach that was done for polio or indeed for blindness. And this is the Run Free 2030 project. We looked at the progress we'd made in spreading the Ponseti method. So in 2015, we were treating nearly 25,000 children per year. But when we looked at the overall estimates of the number of children born worldwide, this only represented 13% of children born with clubfoot around the world accessing treatment. So we were determined to improve that. Here's a global map of those less developed countries in which there is some form of Ponseti type program. But in some cases, only a proportion of children were accessing services. If you look at the way we were building, up to 2016 is the green, and had we just left that to itself, then we'd see the grey line going to the future. But we aspired to the orange graph to make sure that we were seeing a greater proportion of children having access to services and having their deformity corrected and disability prevented. So our vision is a sustainable national clubfoot program in every low and middle income country by 2030. We've targeted 105 low and middle income countries with over 50 clubfoot cases per annum. And 90% of children born with clubfeet worldwide are born in one of these countries. We've rolled out some resources. We have the Africa Clubfoot training material, so a standardized syllabus and teaching materials such that we can ramp up training and education in clubfoot treatment. And we also have an app. Even in Africa now, as Dennis will attest, people have mobile phones. We have an app which has the teaching material on and also enables us to gather data, then it's so much more powerful for our clubfoot treatment programs. We looked at the budget. Over all the countries worldwide, it currently costs about $331 per child to treat the clubfeet. That's an average of Africa, South America, Southeast Asia, India, etc. We broke these costs down into fixed or program materials, i.e. having an office, having the personnel, and the variable, which is basically the cost per individual child. Modelling this for all of our 105 target countries, we estimate we need $160 million in order to meet our target. Unfortunately, we've yet had minimal success in raising this target. A big part of my work now is the surgical treatment of clubfeet. Even in countries where there is an established Ponseti program, up to 10% of children will still need some fine tuning of their correction in order to get full correction and prevent disability. And there's various types of operation. In those children who present early, perhaps up to 10 years of age, only soft tissue surgery is required. In older children and adolescents, and indeed adults, then complicated bony surgery is required. And a lot of my work now is going around the world and teaching surgeons in low and middle income countries how to do these operations well, such that the operation is of good quality, the deformity is corrected, and the adolescent or adult is able to walk and have a fulfilling mobile life. This year, our efforts have been frustrated by the COVID pandemic. Clubfoot treatment often has been seen as an elective service and therefore has been suspended in many countries due to the risk of COVID. However, my clubfoot colleagues around the world are innovative and they basically have used PPE and developed methods by which clubfoot treatment can be done safely. And I'm pleased to say now, after a hiatus of several months, clubfoot services are now restarting around the world. There's Martin, who I introduced you to earlier, who used to walk on his knees. He's now had corrective surgery, difficult bony surgery, which doesn't restore normality, but which got him back onto his feet. He's now a farmer in northern Malawi. I'm sad to say he's a tobacco farmer, but there you are, you can't win them all. He is married, he has children, and the surgery to correct his clubfeet has truly transformed his life. But the answer is not, Martin, it's not surgery. It is the lady you see on the right-hand side of the screen. She's had a little baby. That baby in the first year of life has been treated by the Ponseti technique. With only minimal surgery, that baby's deformity will be completely corrected, and he or she will be able to live and will wear normal shoes, walk, attend school, play games, and ultimately live a fulfilling, happy and mobile life. The Ponseti method is the means by which the tap of clubfoot deformity and disability will be turned off globally. People like myself, I've got a lot of work to do on the Martins of this world, or to train my less developed world colleague to be able to do the surgical techniques to correct his deformity. But the answer is Ponseti treatment delivered by non-surgeons at low cost in less developed world countries. I'm just about to finish now, but before I do, I'd like to make a dedication. I'd like to introduce you to Margaret, the young woman on the left-hand side of the screen. In her mid-20s, she'd had a little girl, Anita, who there you see on her knee on the lawn there. And her husband was a deck officer in the Merchant Navy who was away for up to 9 months at a time. In a hot English summer, she contracted the poliovirus. She was admitted to hospital and rapidly became paraplegic, unable to move either of her legs. She desperately feared having to go into an iron lung. And that experience, that fear, lived with her throughout her life. Thankfully, she recovered and only in the end had mild disability in the form of a dropped foot on one side. 8 years later, she gave birth to a son. That son grew up to be an orthopaedic consultant, and that's me. I'd like to dedicate this talk to my mother, who's sadly no longer with us, but the work of Rotary in the End Polio Now programme has prevented the disability she suffered, and particularly the way she feared being in the iron lung, and the generations now of children that have been free of that. And we are in literally grasping distance of making an end to polio globally. 2 more countries to go. Rotary's had a very important part in this. Let's continue our work. And then once that's done, perhaps consider Clubfoot. Thanks.
Fantastic. Thank you so much, Steve. That was, wow, that was impressive. Really, really enjoyed your talk. Thank you ever so much. There might have been a few folks that were squeamish and had to look away, I'm sure, but we've all been there, and I was at one time as well. But thank you ever so much. Do we have anyone with questions? I know we might have some medics on the call that might have some questions, but anyone else that would like to ask a question of Steve on either polio or his clubfoot work?
Yeah, I do have a question.
Oh, yes, Nick.
Yeah, thanks, Steve, for your wonderful presentation. I'm just wondering, I think I heard you talk about the fact that clubfoot, there are 2 factors, genetic and environmental, and that I think the environmental seems to be more, at a greater level. I'm wondering what the specific predisposing factors, environmental factors are regarding clubfoot, please.
So I have to say enormous amounts of effort has gone into this to try and determine that. Slightly more common in mothers who are smokers. Slightly in some countries, we see a slight regional, a slight seasonal effect. We've tried to see if there's an animal model for clubfoot, but we cannot replicate it. If you look at the chromosomal elements, there are certain genes that are involved in clubfoot, but the expression of those genes is variable. So I wish there was an answer, but we don't know that. All we know is it's not entirely genetic, but we don't yet have an answer for what the environmental stresses are. There are theories. Might it be a virus? Might it be a myelitis type picture? There's no proof of that. no virus has ever been identified. So again, enormous amounts of work have gone into this, but it's not, we're not able yet to give an answer.
Yeah, thanks.
I have a question. If there's not someone else who wants to go.
Go for it, Carla. Carla from Germany. Yeah.
Hi, Steve. Yes, I'm part of the eClub of Southern Scotland, and we have a very flexible schedule for our meetings if you're looking for a flexible club as well. So please bear that in mind. And Dennis is there too. Yes, thank you so much. I am one of the squeamish ones. So I had to look away. I'm so sorry. I can't even take a splinter out of my child's foot. But thank you very much. And I listened and very attentively. I am just, I mean, from my own, it pales in comparison, but from my own experience, my eldest child was in a Paralytic harness from a young age. And I just know the numerous visits to the technician, and I just can't even fathom how that is managed in a country like Malawi, because I think probably there must be a similar requirement for ongoing visits and tweaks along the way, and I just think that would be an added complexity to the program.
So interesting. So first of all, is your child was in a Paralytic harness, which is for developmental dysplasia of the hip.
Yes.
We see almost no developmental dysplasia of the hip in Africa, because babies are carried in the way you see this baby being carried on his mother's back. And that effectively puts the child's hips into the position of a Paralytic harness from very early in life. And therefore that prevents it. So that's the first interesting thing. And the other bit there you alluded to is the clinicians. And in Malawi, we have very few orthopaedic surgeons, but we have a lot of people called clinical officers. They're not doctors. They've done, if you like, an A level, or in Scotland, a higher in orthopaedics, but they are able to provide the basics of orthopaedic care to even remote rural communities. And that's another great advantage. Their qualification isn't marketable. They can't come and work in the UK, but they stay where they are in their rural communities, and they provide a truly excellent service. So Malawi, for all its poverty, for all its lack of surgeons, actually has a better overall standard of orthopaedic care than some of its neighbours, because of this particular grade of clinician.
That's fantastic.
Thanks.
Thank you again.
Hi, Judith, from Wisconsin in the United States.
Yes, I'm from Oconomowoc, Wisconsin, United States, but I belong to the eClub of Southern Scotland. I worked for a time in Botswana in an HIV pediatric clinic. And one of the things that we dealt with, and you mentioned this briefly, witch doctors, or as we would call it, traditional healers. And that proved to be an issue both physiologically and psychologically. And especially when the traditional healers would offer things to ingest that would work against the drugs. So what do you find in the areas that you've been, and how do you deal with those kind of the Western medicine and the traditional healing?
So a really good point. So we found that when I started in Malawi, there was this bit where children with club feet were taken first off to the traditional healer. They would undergo scarification. There'd be all the little cuts over the foot. And the answer to it, I think, really was the awareness program, to make mothers aware that club feet wasn't witchcraft, that it could be treated, to make midwives aware. A large proportion of Malawian women do give birth in hospital, and to make the midwives aware that this is club feet and it can be treated through conventional medical routes, and there's no need to involve traditional healers. And then eventually for the traditional healers themselves to recognize, traditional healers do have knowledge, they are approachable, for them to know that club feet is not witchcraft, and that there is a means of accessing treatment through the local district hospital, and for treatment to be given and the deformity corrected. So all those levels. And now we really do in Malawi have a very high rate of correction of the deformity. with everybody being on side largely.
Thank you.
Any more questions? No.
I've got another one. I don't want to go twice. But...
We'll give you one more. We'll give you one more, and then we'll ask President Lynn to wrap up.
Yes, about a year ago or so, we had on a man who lives in England, if I remember correctly, who had polio as a child, and he does do quite a few talks to Rotarians. But one of the points that he made was those who still suffer from polio and its effects feel a bit forgotten about Rotary because the campaign is to end polio. And he said, what about all of us who are still dealing with the effects of polio? And I also asked that too, because my husband Richard is on, and his father had polio as a 4-year-old, and then post-polio syndrome a bit at the end and so on. But I thought Colin's point was very poignant, really. All this polio talk, but what about the people who are still suffering with it?
No, I completely agree. So, for example, in Africa, to have the orthotic workshops, so the braces and the splints can still be provided, have the wheelchairs and the seating aids, really important. To not lose the skills on the surgery. Some of the surgery for polio is very unique. And I think our modern generation of surgeons are losing those skills. The tibialis posterior tendon transfer is unknown in the United Kingdom to my colleagues. And if largely, now it's unknown to surgeons in Africa. And that's part of I see as my role, to continue to advocate for services for polio-related disability. Yeah, no, very important. I absolutely agree with that. Yeah.
Thank you.
Okay, I think if that's it, Steve, for me, thank you very, very much for joining us tonight. I think President Lynn would want just to say a few words to say thank you. Lynn, you're on mute. You're on mute. Sorry.
Right. Okay. Sorry about that. So just wanted to say thank you so much, Steve. That was absolutely great. I think quite often, you know, we talk about End Polio now as part of, you know, we know Rotary it's very big, but sometimes we forget the history and we forget exactly what Judith was saying, that people even in this country are still living with it. I remember when I was at school and our schoolmates wore calipers, he had polio, he was in terrible pain, and that's something I always remembered. And also one of my favourite musicians, Steve Harley of Steve Harley and Cockney Rebel, some of you might remember that. He had polio, and when he used to come on stage, the stage went black, and then he appeared because he didn't want people to see the disability that he had. And it's only now that he actually walks on stage and he walks off it. So, you know, very much people even in this country are still living with it. But it must be so rewarding for you, you know, the pictures you show when you see the difference you make to people's lives after surgery and how it completely transforms them and they can go on and have great careers. So that, I guess, must be one of the most rewarding things that you get from the work you do, which I realise is very, very varied. So thank you so much for coming here, especially on a Saturday night. It's been great, and we hope, you know, you can come and talk to us again. We would love that. And you're always welcome to join our club.
You're here. I'll make sure he does. I'll make sure he does.
I'm sure Dennis will follow me up on that one.
I will work. I owe him a few. I owe you a few beers for this talk tonight. Thank you ever so much. Thank you, Steve.
You say that again.
I will. I'll catch up. Trust me. And I hope everyone has a very pleasant evening and the rest of the weekend. So thank you very much indeed. Thank you.
I was going to ask if you could circulate your fundraising efforts as well, the link to your fundraiser.
We will,
the very ambitious 160, but yeah, I assume that any contribution can assist.
Yeah. So thank you, that'd be great.
Okay,
Well, maybe
perfect.
you can maybe join us on a Wednesday night sometime, Steve, to talk about that in the
That'd be
future.
super.
Lovely. Yeah, great. Thanks.